Let's start with normal sinus rhythm, the gold standard of heartbeats. The rhythm is regular, the rate is between 60 and 100 beats per minute. Good news? NSR is a sign your heart is happy. Next up, sinus bradycardia, where the heart is a bit too laid back, beating less than 60 times per minute. If symptoms like dizziness or fatigue pop up, we treat it with atropine or pacing. Opposite to bradycardia, sinus tachycardia is a heart in a hurry, racing over 100 beats per minute. Treat the cause, hydrate if you're dehydrated or use beta blockers. Now, let's talk about chaotic rhythm, atrial fibrillation or AFib. Hypertension, heart failure, and too much alcohol can spark AFib. We control the rate with beta blockers and use anticoagulants to prevent clots.
Atrial flutter. Unlike AFib, atrial flutter is more organized, showing a sawtooth pattern. Think of it as your heart flapping its wings like a butterfly. Causes: common culprits include CAD and lung diseases like COPD. Rate control with meds, rhythm control with ablation, and anticoagulation to prevent strokes. 6. Supraventricular tachycardia. SVT is a super speedy rhythm originating above the ventricles, often faster than 150 beats per minute. It's like a rocket taking off. P waves may even vanish. Memory trick: SVT is super vroom tachycardia, fast and furious. Treatment: try vagal maneuvers like bearing down, or use adenosine to reset the heart. For severe cases, synchronized cardioversion works like magic. 7. Ventricular tachycardia. Now we're entering dangerous territory with ventricular tachycardia. Wide QRS complexes make it look like shark teeth. Causes: it's often triggered by MI, low electrolytes, or cardiomyopathy. Treatment: stable VTAC, use meds like amiodarone. Unstable, go straight to synchronized cardioversion. Long-term, an ICD can be a lifesaver. 8. Ventricular fibrillation (VFib). Graphic: totally chaotic rhythm, no identifiable waves. Host: from VTAC to Fib, where chaos reigns. This is a cardiac emergency. Imagine static on a TV screen. Treatment: immediate defibrillation and CPR are the only way to bring order back. Follow with epinephrine or amiodarone. Asystole: a flat line on the monitor. And finally, the dreaded flat line, a systole: no electrical activity, no heartbeat. Memory trick: flat as a pancake, nothing left. Treatment: CPR and epinephrine are your go-to, and always check for reversible causes like hypoxia or hyperkalemia.
Question 1. A patient's ECG strip shows a regular rhythm with a rate of 70 bpm. The PR interval is 0.18 seconds and the QRS complex is 0.08 seconds. What is the interpretation of this rhythm? Question 2. On an ECG strip, the PR interval is prolonged at 0.24 seconds, but the QRS complexes are regular and normal in duration. What is the interpretation? Question 3. The ECG strip shows an irregular rhythm with no identifiable P waves and a ventricular rate of 120 bpm. What is the rhythm? Question 4. A patient's ECG shows sawtooth-like flutter waves between QRS complexes at a rate of 300 bpm. What is the rhythm? Question 5. An ECG strip reveals 3 or more consecutive PVCs with a ventricular rate of 150 bpm. What is this rhythm? Question 6. On an ECG strip, the PR interval progressively lengthens until a QRS complex is dropped. What is this rhythm? Question 7. A patient's ECG shows a constant PR interval with occasional dropped QRS complexes. What type of heart block is this? Question 8. On an ECG strip, there is no relationship between P waves and QRS complexes. The atrial rate is 70 bpm and the ventricular rate is 30 bpm. What is the rhythm? Question 9. An ECG strip shows ST segment elevation in leads 2, 3, and AVF. What does this finding suggest? Question 10. What does ST segment depression on an ECG strip typically indicate?